So, who's Dr. Danielle Renner. She works in Kaylee's lab. And since I don't make a mistake, she's a postdoc. Right. All right. And she's going to be talking about single-cell sequencing of macrophages in primary and metastatic tumors.
Okay, thank you for the introduction. As mentioned, I work for Dr. Kaylee Schwartfeger, and we are interested in understanding the tumor microenvironment, particularly in the context of breast cancer. And my project specifically looks at metastasis in comparison to primary tumors. So the rationale for this particular project is that there are very few effective options for breast cancer, particularly triple-negative breast cancer, which is what we focus on. And this is despite the fact that metastatic disease is the primary cause of death in most of these patients. So these patients will have recurrent disease, and there are very few options available for treating them. The majority of preclinical studies, so things in mouse models, in vitro, focus primarily on the primary tumor, and relatively little is known regarding the impact of the immune environment at metastatic sites, despite the fact, as I mentioned, that this is the primary cause of death. So we know really little about what happens once these primary tumors spread out into metastatic sites. For breast cancer, the primary sites for metastasis include lung, brain, bone, and liver. And what I'm going to talk about is going to be lung, which is one of the more common sites for the mouse models that we have available. One of the things that we do know is that macrophages have been extensively studied as contributors to breast cancer growth and metastasis. So we know that macrophages do promote a number of different processes. This includes inflammation. They regulate the immune system, so they can either stimulate things like cytotoxic T cells, or they can contribute to entry of things like regulatory T cells. They can secrete either pro or anti-inflammatory cytokines. They also play a role in angiogenesis, so they can secrete factors like VEGF that promote angiogenesis within tumors and metastatic sites. And of interest, particularly for my project, is that they also regulate things like tumor cell invasion and seeding at distant sites. So they can secrete cytokines that promote the entry of tumor cells into some of these distant sites in this pre-metastatic niche. And when it comes to breast cancer patients, you can see here, this is a look in the primary tumor site looking at the density of macrophages, and a higher macrophage density within the primary tumor leads to a shorter survival for these patients. So in the majority of cases, macrophage density in breast cancer is correlated to negative survival outcomes. So we're really interested in understanding what these macrophages are doing and how we might be able to either sort of suppress their pro-tumor activity or amplify their anti-tumor activity. Furthermore, we know that macrophages are present in both primary and metastatic tumor sites. So this is some F480 staining in one of our mammary mouse tumor models in both the primary and lung metastases. So you can see the brown staining there is F480. We also know that macrophages are highly heterogeneous populations. So there are different sources of macrophages. So there are tissue-resident macrophages that are present in all the tissues, including the lung, which is one of the main organs that I'm looking at. So we have these resident tissue macrophages that come from the yolk sac or fetal liver. And then we also have this more classical model of monocytes being recruited into a tissue and maturing into macrophages. And there's very little known about how those two different populations promote tumor progression. We also know that they can be localized differently within the tumor. So there might be different features, whether macrophages are located near vessels or within the lymphatic system. We know that those can also play different roles. Recent CyTOF analysis in a renal cell carcinoma showed that there were 17 different macrophage populations within that study. So we know that this is a very diverse group. This is not just one type of cell doing one thing. If you've heard macrophage talks before, you've probably heard this M1 to M2 paradigm. There's probably more like M40, 50, 100 and something. So we try to kind of stay away from that a little bit and kind of think more about the dynamic processes that these cells are going through. So they probably express a little bit of one and a little bit of two, and they're really something, a little bit of both and something in the middle. So we're trying to really understand how these individual populations can be identified and how we can kind of capitalize on understanding how these different populations are different. And going back to this resident macrophage point, is that they can have different effects on the tumors based on which organ they're in. So it's not just that a tissue resident versus a bone marrow derived macrophage is different. Depending on the tissue that you're starting in, that niche of that tissue is also going to lead to the resident macrophages kind of having different features as well. So to just give you a couple of examples of that, this is a paper in Immunity looking at tissue resident macrophages versus bone marrow derived macrophages in a pancreatic ductal adenocarcinoma. So they used some lineage tracing techniques in their mouse model to show that the tumor-associated macrophages that they were able to identify came from both monocytic origin as well as embryonic precursors. They showed that in this particular tissue, the cells that were tissue-resident macrophages were the ones that were promoting tumor progression, and that the ones that were monocyte-derived were playing more of a role in antigen presentation and therefore more likely to have more of an anti-tumor function. There have also been similar studies done in brain malignancies. So in this particular paper, they looked both at primary brain malignancies and brain metastases, and they're able to show that there are different transcriptional profiles and different epigenetic profiles correlating to whether they were peripherally derived bone marrow macrophages or tissue-resident microglia within the tissue. So they were able to identify a couple of different markers where they were actually able to say that one was of one origin versus another. So another complication in the field is not just that these macrophages are heterogeneous, but there's not necessarily great markers to be able to say this is specifically this type of macrophage or this is specifically that. So that's actually one of our goals as well, is to identify some of these markers that we can use to say this is this type of macrophage. So it's kind of a proof of principle that they were able to identify a tissue-resident marker to distinguish those from bone marrow-derived cells. So the hypothesis behind this particular aspect of my project is that the recruitment and activation of distinct populations of macrophages allows for memory tumor growth and the establishment of lung mets. So the overall long-term goal would be to be able to identify these different macrophage populations and then to be able to develop more effective therapies that inhibit the pro-tumor functions and kind of enhance the anti-tumor potential that we know that macrophages can have within established metastatic lesions, so that we can actually improve the treatment of these breast cancer patients. So just to give you a little bit of an idea of kind of how I've spent the time for this Great Idea Award that we received from LMP, we spent the first few months optimizing the macrophage isolation and cell sorting. So the markers for macrophages are a little bit less identified and than something like a T cell. So we scoured the literature and tried to find a few different markers that we could use that would really help us identify this population. So once I felt pretty confident that I could sort out macrophages, we transplanted 41 luciferase cells, which is a mammary triple-negative like breast cancer line, into the number 4 mammary gland of wild-type BALB/c mice at a primary tumor volume of about 1.25 cubic centimeters, which is a time point when we've seen significant metastases within the lungs of these mice. We harvested matched primary tumor, and the METs flow sorted on the markers that we've identified, and then submitted these samples to UMGC for 10x single-cell sequencing, where they've been working on the library prep QC sequencing of 10,000 cells at 50,000 reads per cell. And I'm now working with the bioinformatics group to look at the analysis of the single-cell sequencing. So we met with Todd last week, and I think I'll be getting to know him a little bit over the next few weeks as we kind of try to figure out how many different little blobs are, how many different colors we can make our little blob into, and see if we can start identifying some of these additional markers to be able to say that we have, one set of macrophages over another. So just to give you a little bit of an idea of what the sorting looks like. So this is from, this was the help of Jason and the flow core. We basically took live single cells that were CD45 positive, Ly6G negative, which would be more of a granulocytic marker, and then sorted MERTK CD64 positive cells. So these have been identified to be a little bit more consistent throughout tissues. So most people are probably familiar with F480 as the marker of macrophages. F480 has been shown to be kind of dysregulated within tumors. So while I see it, really strongly expressed in a spleen, I might not necessarily see it in every tumor sample. And a large genomic analysis identified CD64 and MERTK as good identifiers of macrophages from essentially every tissue. So since we're looking at a matched mammary tumor and lung, we wanted to make sure it was something that was going to be well expressed throughout both tissues. Looking at the post-sort analysis, this little box is the cells that I identified. So the sorting efficiency was somewhere between 60 and 90% depending upon the sample. So we took the higher efficient sorted samples and were able to get a viability of, in the tumor, about 75 to 85%, and in the lungs, 85 to 95%. So we had pretty good viability that was able to pass the QC check for the 10x sequencing, and then those samples were submitted for the 10x. So to our knowledge, these will be the first studies that use single-cell sequencing to compare the macrophages from a primary and matched metastatic tumor. And like I said, one of the goals that we have is to be able to identify novel markers to be able to identify these distinct macrophage populations in the future. So if we can say that a particular type of macrophage always expresses a particular marker, we can then take that back into the lab and say, for immunofluorescence, for example, we can look within the tissues and say, this type of macrophage seems to be, more near tumor cells or more near vasculature, or expressing suppressive markers or immune stimulatory markers or something like that. So we can kind of start using that for some co-staining in immunofluorescence. And then ideally, we'd like to then move forward and be able to match this with human samples from primary and metastatic cancer and say, do these mouse models recapitulate the numbers and types of different macrophage populations that we're seeing within the mouse model. And then this data will also be used for the preparation of some manuscripts where we can look at the differences in these immune responses between these tumors. So that's it. I would like to acknowledge my lab, particularly Kaylee, as well as the other members of the lab, some of our collaborators, LMP for the Great Idea Award that kind of gave us the funds to get this started, and the American Cancer Society for funding through their post-doctoral fellowship. So, any questions?
This might show my naivete, but it seems to me counterintuitive that a macrophage that is very capable of processing antigens and presenting them to the immune system be associated with a worse prognosis. And my question is, have you been able to look at the way these macrophages are able to process and present antigens to the immune system? Because this seemed to me to be, because there is variability in the way macrophages do this. Have you figured out a way to do that?
We haven't looked too mechanistically. So most of the work I've done so far is just on cell surface markers. So we are able to see that different populations might express more like MHC class 2 and co-stimulatory molecules that would be involved in antigen presentation. But there are other populations of macrophages, particularly those within the tumor, that actually downregulate all of that machinery and upregulate more immune suppressive type things, and then they'll secrete these cytokines. So what we're trying to do is identify which populations are which. We kind of have a hypothesis that based on some of the literature and some of the data that we have, that some of these tissue-resident macrophages that are in this pre-metastatic niche as the cancer cells first start to come out there are reprogrammed to secrete some of these anti-immune, pro-tumorigenic cytokines and things. So we haven't yet, but we're trying to kind of come up with the tools to really be able to parse out why these populations are different and why they're not necessarily responding in a way that you'd expect them to.
I have one question about
the
50,000 reads per cell.
Mm-hmm.
Do they have some special? Just had a question about the 50,000 reads per cell since trying to discover new markers.
Yeah.
Do they have some special way of kind of normalizing? Are they applying in their pipeline? Because otherwise, I think you might just get like a lot of abundant RNAs taking up most of those reads. Is that an issue, or you're kind of still in the midst of the analysis?
Yes, still in the midst. Like, we got the data yesterday. So it just came out of the pipeline. I do think you're right. So I don't think we're necessarily trying to go down. We did more of a breadth than a depth. So we're not necessarily saying that we're going to identify like a particular variant that's very rare, or some of these, really small populations, I think what we're trying to do is say, right now we basically have there are a couple of identified markers, for example, the lung tissue resident macrophages or something, but there's really not a lot of surface markers that we can use. So it might not necessarily be a new rare variant that we're identifying, but we might be able to say, oh, we didn't realize that, this level of CX3CR1 or CD11B or, whatever these surface markers are might be correlated to something that we might be able to say is, immune suppressive versus immune stimulatory. So I'm admittedly very naive on the analysis part of it, and Todd and I will become very good friends over the next few weeks, so I can kind of learn that. But yeah, I think we did know that, we're not necessarily going to get these really minutia, but we're kind of hoping to be able to say, some of these markers that are already known, but we don't necessarily know how they interact on different cells. We're kind of looking more at that level, I think. Jim?
Very interesting stuff. So, my own naivete to go with John's naivete.
Yeah.
M2 macrophages in a wound promote healing, promote fibrosis. Essentially, it's a chronic wound. And you didn't list anything relative to fibrosis in terms of some of the things you're looking at. So is anybody looking at that in terms of are these M2 macrophages actually creating a fibrotic environment? I know there's certain types of breast cancer that have a lot of collagen around them, that sorts of things. Is there anybody looking at something like that, which would impact on therapy and perhaps progression?
I'm sure that there are. Maybe Kaylee can help me out here if she knows any more on this than I do. I think, do you want to hand Kaylee a microphone? She looks...
I think that there's a ton of work being done on macrophages in general, and I don't think there's a lot of work on their modulation of ECM fibrosis. Most people are studying cytokines that suppress T cells or act on tumor cells, but it's a very relevant hypothesis. Yes, what you just said was a very relevant hypothesis.
Yes.
Would you like to work on it?
All right. Thank you, Dan.
Thanks.